Today we will be having a discussion about the angina. Angina is the transient reduction of blood supply to the muscle of the heart, but there is no damage to the cardiac muscle. And this one feature actually differentiates it from the myocardial infarction. In the myocardial infarction, there is not only the reduction of the blood supply to the muscle of the heart, but also there is damage to the cardiac muscles. So there are two types of the angina, stable and unstable angina. But before we go into the details of these two types of the angina, we need to understand the major cause of the angina. One major reason why patients have angina is the thrombus formation in the coronary arteries in majority of the cases. The exceptions are the Prince-Metters angina or the vasospastic angina, in which cases there is no thrombus formation in the coronary arteries, but there is a brief or transient spasm of the coronary arteries which causes the cardiac ischemia or reduction in the blood supply to the muscle of heart. Now, there are certain risk factors involved in the formation of the thrombus in the coronary arteries. There are two types of the risk factors. One are the non-modifiable risk factor and one category is the modifiable risk factor. Non-modifiable risk factors are those which cannot be modified by any means. There are three major non-modifiable risk factors. One is gender. Males are more predisposed to have coronary artery disease, but this happens only as long as the female is not postmenopausal. Premenopausal females are actually protected by their hormones from having the coronary artery disease. So being male puts person at risk of having coronary artery disease more as compared to female. Then comes the age. With increasing age, especially after the 40 years of age, there is an increased risk of having thrombus formation in the coronary arteries and coronary artery disease. Then there is a family history. Those persons who have got a strong family history of coronary artery disease or angina or myocardial infarction, they are predisposed to have angina. When we say the family history, there are many members of the family who have got the heart problem at an early stage of their life. So these three are the non-modifiable risk factor: gender, age and family history. Now there are certain risk factors which can be changed with efforts, and they are known as the modifiable risk factor. What are those modifiable risk factors? Smoking. One can stop smoking and be better, and can decrease the risk of having coronary artery disease or angina or myocardial infarction or thrombus formation. Then there is hypertension and diabetes mellitus. If one tries to have a better control of these two diseases, one can lower the risk of having myocardial infarction or angina. So cigarette smoking, hypertension, diabetes mellitus, higher cholesterol level, a sedentary lifestyle, obesity, and type A personality. All these are the modifiable risk factor which can be actually modified, which can be engaged in a way that one can have a lower risk factor of developing angina or MI. There are two types of the angina, stable and unstable angina. The patients with the stable angina actually develops chest pain during exertion or because of some stress, and is relieved. This chest pain is relieved by the rest or taking nitrates. For example, nitroglycerin, which comes in Pakistan with the name of Angicid, 0.5 milligrams sublingually. There are chances that once the patient gets relief of the chest pain within 5 minutes, patient will not be bothering to visit ER. But if patient comes to the doctor or emergency department, then the best strategy and chances are that his or her ECG would turn out to be negative. There will not be any finding in the ECG because the patient has already got rid of the chest pain. But even if it is negative, the best strategy would be to advise patient exercise tolerance test, because using this test, there are chances that we can actually know about the potential thrombus sitting in the coronary vessel. If exercise tolerance test is positive, then we can advise patient to have angiography, which is a test to actually look into the coronary arteries, and if there is a thrombus, we can plan either angioplasty plus stenting, which we call angiography plus angioplasty is known as percutaneous coronary intervention, or we can even plan CABG in the future, depending upon the status of the coronary vessels, because if there is a triple vessel disease or the anatomy doesn't allow you to go for the PCI, then you can actually go for the CABG. So in any case, these patients who are coming to the hospital and they are there are chances that they have stable angina, they should be advised to actually take care of their modifiable risk factor. They can do exercise, they can stop smoking, they should actually lose weight, they should have a better control of their diabetes and glucose. They should take proper care of their diet. They should be having less fats and more carbohydrates, dash diet. So a patient of stable angina most of the time has a prescription paper containing these medication tablet. You can put patient on the tablet Loprin 75 milligram 1 OD, tablet clopidogrel, which comes here with the name of Plavix 75 milligram 1 OD. You can put patient on the anti-hyperlipidemic, for example, rosuvastatin, for 20 milligram in the evening or night. Then you can, for the chest pain, patient can be prescribed glyceryl trinitrate or nitroglycerin, which comes here with the name of Sustac 2.6 milligram 1 BD. If the heart rate is more than 80 or 90 beats per minute, patient can be prescribed beta blocker. For example, we can give carvedilol, which we use here with the name of Korlov 3.125 milligram BD twice in a day. Patient should be given insulin or oral hypoglycemic for the control of the blood sugar level if the patient is diabetic, and patient should be taking very good care of the blood pressure level if patient is a known case of hypertension. So all in all, these are a group of the medication which a patient of the stable angina should be using. And obviously there should be a workup going on, which I already mentioned, exercise tolerance test. If it is positive, go for angiography. And if there are findings in the coronary vessels that there is a thrombus sitting in any of the coronary arteries, then in the future, angioplasty or CABG can be planned according to the findings of the angiography. The second type of the angina is unstable angina. This type of angina is worse than the stable angina. Patient develops chest pain during the rest and there is no exertion involved. It is not relieved by the nitrates, and the duration is more than 5 minutes. Most of these patients actually present to the ER because by the time they reach the ER, still they have got the chest pain. When they get their ECG, there are certain changes in the ECG which actually tell us a lot about the nature of the unstable angina. But before we go into the details of the ECG changes, we will first will have to consider three aspects of the heart. There are three walls of the heart: anterior wall, inferior wall, and the lateral wall. Heart is sitting like a fist in the chest. It has got inferior wall, anterior wall, and lateral wall. There are three set of coronary arteries which supplies to these respective walls of the heart. Right coronary artery supplies inferior wall, and because it subdivides into two branches, posterior descending artery and right marginal branch, 60% of the time it also supplies SA node, and right coronary artery supplies right atrium and the right ventricle. So right coronary artery supplies mainly inferior wall. Then left main stem divides into two coronary arteries. One is the left circumflex artery and one is left anterior descending artery. Left circumflex artery supplies lateral wall, and 40% of the time it also supplies SA node. Left anterior descending artery supplies anterior wall. Now there are three sets of the ECG leads which represent the respective walls. For example, lead 1 and AVL, which are the limb leads, they represent lateral wall. Lead 2, 3, AVF, which are again limb leads, they represent inferior wall. And lead V1 to V6 in all they represent anterior wall, but they are subdivided into V1 and V2. They are known as the anteroseptal leads. V3 and V4 are known as the pure anterior leads, and V5 and V6 are known as the anterolateral leads because they are located on the lateral side of the left ventricle. and V3, V4 are located right in front of the left ventricle, and V1 and V2 are located more towards the septum. These are 6 chest leads which represents anterior wall, and other walls are represented by the limb leads. 1 AVL lateral wall, 2 3 AVF inferior wall. So now when we know that a certain set of the ECG leads represent a certain wall of the heart, and that wall of the heart is supplied by a certain coronary artery. So when a patient of unstable angina is coming to the emergency department and we do the ECG, there would be certain changes in the ECG. There can be T-wave inversions or there can be ST depression. In T-wave inversions, T-wave has actually become a negative deflection, and this is known as a symmetrical T-wave inversions. And in ST depression, the J point or the junctional point between the S and T wave actually goes down, and along with it draws the S and T. I'll show in picture how it looks actually. So there are 2 types of changes, T-wave inversion and ST depression. Now by looking at the ECG changes of a patient of a chest pain, we are now sure of one thing, that there is an ongoing cardiac ischemia. It can either be unstable angina or it can be non-ST elevation MI, and this differentiation is based on the positivity or negativity of the cardiac enzyme, because we send the cardiac enzyme at 0 hours and 6 hours. Most of the time it takes cardiac enzyme 6 hours to be positive, or obviously they can be negative. If a patient comes with a chest pain in the emergency department and ECG has got these changes, T-wave inversions or ST depression, and cardiac enzyme, if they are positive after 6 hours, we call it non-ST elevation MI. But if the cardiac enzyme are negative, we call it unstable angina. There are 2 sets of the cardiac enzyme. One is troponins, including troponin I and troponin T, and one is CKMB, creatine kinase MB segment. So of the troponins, troponin I is very cardiac specific, and troponin T turns out to be falsely positive in cases of the sepsis, surgery, or some chronic kidney diseases, in pregnancy, in trauma. But troponin I, quantitatively if done, is very much specific of the heart diseases, especially the non-ST elevation MI. Now the patient is present in the emergency department. Patient has got his or her ECG, and we know that there are certain changes in ECG, T-wave inversions or ST depression. If the change of T-wave inversions or ST depression is in 1 and AVL, then we call it lateral wall ischemia. If the change is in 2, 3 and AVF, we call it inferior wall ischemia. And if the change is in V1 to V6, we call it anterior wall ischemia. For example, if the change is in V1 and V2, we call that the patient is having anterolateral ischemia. V1, V5 and V6, anterolateral ischemia. Here I am using the word ischemia, neither angina nor MI, because the difference would be made after we have got the reports of the cardiac enzyme. If the cardiac enzyme are positive, we will call it unstable angina, and if cardiac enzyme report is negative, we will call it non-ST elevation MI. Because the management of both unstable angina and non-ST elevation MI is same, so rather than waiting for the result, we will start the management outrightly. The management is plan A and plan B. Plan B, A is a pharmacological management, and plan B is the intervention. It actually depends upon the facilities available in the hospital. If there is no catheterization facility available in the hospital, the medical management can be started. In order to remember the medical management of patients of the unstable angina and non-ST elevation MI, there is a mnemonic with the MONA B, MONA/B. M stands for the morphine. Because the patient has presented with a chest pain, morphine is given. Morphine is an opioid analgesic, and it is given to relieve the chest pain even after the nitrates if patient hasn't settled with the pain in the chest. So morphine comes with a dose range of 5 milligram injection. We can give 2.5 milligram each time because it's an opioid analgesic. It causes respiratory depression. It causes hypotension. So one needs to be very watchful while giving a morphine. Then in the mona/B comes the O. O is for the oxygen. As long as the patient saturation stays more than 94%, we do not need to give any extra oxygen. But if saturation is less than 94%, better we start giving oxygen through the nasal cannula so that the saturation can be maintained more than 94%. The next thing is N. N is nitrates. Nitrates are venodilators, so they can be given to increase the oxygen supply to the endangered myocardium. There are certain brand names and certain generic names, like we can give nitroglycerin, glyceryl trinitrate, we can give isosorbide dinitrate and isosorbide mononitrate. Any type of analgesic can be given, nitrate can be given. But one needs to be very careful whenever a patient is presenting with right-sided MI, right-sided ischemic changes, like if there are changes in the lead 2, 3 and AVF and right coronary artery suspected to be the culprit vessel, better avoid giving nitrates because these can cause hypotension to a greater extent. And avoid giving nitrates if blood pressure is less than 90 systolic blood pressure. The next thing which comes in the mona/B mnemonic is A. This is very important segment of it. A has got two categories. One is antiplatelets and one is antithrombotic. In antiplatelets, there are two types of antiplatelets. One is Disprin, which we give in a standard dose of 300 milligram, and we give non-enteric coated. We ask the patient to crush it and chew it. We want its instant reabsorption because there are two medications which save life. One is Disprin and one is beta blocker as per needed basis. So we give Disprin 300 milligram per hour, and we ask the patient to chew it rather than like swallowing it. Then the other antiplatelet is clopidogrel. We give it with the name of the Plavix or no clot or low plate 75 milligram, 4 tablets. We ask the patient to take it with a sip of water. It doesn't need to be chewed actually. Then in antithrombotic comes either you give injection heparin, which is unfractionated heparin, 5000 international unit IV stat, and 1000 unit per hour infusion is started. The aim is to keep activated partial thromboplastin time 2 times the normal. Normal value of the APTT is, this is a lab test, APTT is 35. We are to keep it around 50 to 70. In that way we can keep the blood thin. If we do not go with the option of unfractionated heparin, we have an option of low molecular weight heparin, which is enoxaparin, and here in Pakistan we use with the name of Clexane. It can be given in a dose of 1 milligram per kilogram 12 hourly, and it is given subcutaneously because it acts on the activated factor 10, so there is no need of lab monitoring for these patients. When I told mnemonic mona/B, B stands for beta blocker. Why we put it slash? Because this drug is an optional drug. For example, if a patient comes in ER, has got chest pain, has ECG changes, and heart rate is more than 100, more than 90, so demand is more as compared to supply. And in those kind of patients, we will use this beta blocker, preferably metroprolol. Here it comes with a brand name of Lopressor. We can give injection Lopressor 5 milligram in incremental doses of 2.5 milligram. Watching for the hypotension, bradycardia, and obviously there is a contraindication of beta blockers. It should be avoided in asthmatic and those with the bronchoconstriction. It can aggravate it. But if patient needs it and patient tolerates it, then we can switch the patient later on to the tablet metoprolol, which comes here with the brand name of the Mipressor and Mirol. It's a 100 milligram tablet which can be given 6 hourly in the quarter doses, 25 milligrams 6 hourly, in order to keep the heart rate less than 100 beats per minute, because it's a demand and supply problem, because supply is compromised because of the thrombus in the coronary vessel. So better we keep the demand checked, we keep the demand within a certain limit, and that is another reason of giving patients some anti-anxiety medications orally even after this acute episode settles down. Now, if this very same patient who came with a chest pain and has ECG changes of TVR inversions and ST depression, he has presented to a hospital which has the facility of cath lab or catheterization lab, then patient can be we offered plan B. In plan B, what we do intervention. We shift the patient to the cath lab and we do the angiography. As literally speaking, angio stands for blood vessel and graphy mean picture. So by doing the angiography through the radial artery or the femoral artery, we try to know the status of the coronary vessels if there is a thrombus sitting in any of the coronary arteries. Once we have done the angiography, then we can plan angioplasty. Again, literally speaking, angio mean blood vessel and plasty mean repair. We can remove that thrombus, but because there are chances of reocclusion, so we can do angioplasty plus stenting. We can place a stent over there so that it doesn't let the artery collapse or the thrombus reform over there. This process of doing the angiography plus angioplasty is known as the PCI, percutaneous coronary intervention. Now, there are some exceptions. For example, if on angiography we find out that the three vessels of the patient are affected, it is known as the triple vessel disease, or there is a problem with the anatomy of the coronary arteries, and if we do the angioplasty, there are chances of rupturing of the coronary vessels, then we can plan coronary artery bypass grafting, also very famously known as CABG, C-A-B-G, coronary artery bypass graft. So the indication of CABG is triple vessel disease and difficult to engage anatomy of the coronary arteries. Now if we look at this ECG, it shows symmetrical T-wave inversions where I have placed arrows. These symmetrical T-wave inversions are present in lead V1, V2, V3, V4, V5 and V6. Almost a complete set of those leads which represent anterior wall, they have got this cardiac ischemic sign, a T-wave inversion. Patient came with the chest pain, we did the ECG, there are these changes present in the ECG of the patient, T-wave inversions in lead V1 to V6. This set of the ECG leads V1 to V6, it represent anterior wall, and anterior wall is supplied by the left anterior descending artery. So we will call it anterior wall ischemia. If cardiac enzymes are positive, we will call it non-ST elevation MI, and if the cardiac enzyme are negative, we will call it unstable angina. And chances are, if it is positive or negative, whatever the case is, on angiography we can find something with the within the left anterior descending artery. Now this is another patient, and in this patient, if we look at lead V2, V3, V4, V5 and V6, we find ST depression. The ST segment is going a little bit lower than the isoelectric line. J point is going down, so we call it ST depression. Patient came with the chest pain. We have got these ST depression in the almost except one, all of the anterior leads, and we will do the cardiac enzyme. If they are negative, we will call it unstable angina, and if the cardiac enzyme are positive, we will call it non-ST elevation MI. So this is a ST depression. And if I zoom a little bit more, you can appreciate that there are ST segment going down. And if a patient is coming with the chest pain, this is a very, very significant finding in ECG, because it points toward cardiac ischemia, which can be subcategorized based on the cardiac enzyme status, but the management will stay the same. Pharmacological one goes with the MONA B, and interventional goes with the angiography. Findings of the angiography will dictate whether the patient needs PCI, percutaneous coronary intervention, i.e. angioplasty and stenting, or patient needs CABG, coronary artery bypass graft, depending upon the findings of the angiography.